down to my level a little bit. Sorry, thank you. All right. As John said, my name is Nitya Sharma. I'm a Quinnipiac student. My presentation today will be on the comparison of ECPR and mechanical CPR and out-of-hospital cardiac arrest. According to the American Heart Association, roughly 100,000 adult out-of-hospital cardiac arrest cases occur annually in the United States, with 90% of those being fatal. Cardiac arrest occurs often in the outside hospital setting, where the initial care is initiated by bystanders and later first responders. 37.7% of the cardiac arrests were witnessed by civilians, with only 12.7% witnessed by EMS providers. That's leaving roughly about 50% cases unwitnessed. The survival to hospital discharge was 10.4%, with only 8.2% having acceptable functional status. The survivability primarily relies on rapid EMS response and high quality CPR given by both first responders and bystanders at the scene. The Lund University Cardiopulmonary Assist Device, or the Lucas device, was developed to provide portable mechanical chest compressions that is not influenced by the environment, mental or physical strength of the rescuer, or chest compression interruptions. The failure to maintain the recommended compression rate, depth, and continuity results in periods of considerably longer no-flow times. The Lucas device is a gas or electric-powered piston device that provides consistent rate and depth chest compressions. It includes a suction cup that attaches to the sternum that ensures the sternum returns to the starting position, thus assisting in the decompression phase of CPR. Studies have been conflicted in regards to the superiority of the Lucas device over manual chest compressions. The overall advantages of the Lucas device are the decreased need for manpower, guaranteed effectiveness, and eliminates fatigue as a factor. ECPR, as we all know, is the implantation of VA ECMO in individuals who are experiencing cardiac arrest. Optimal technique with conventional CPR only delivers approximately 15 to 25% of normal cardiac output. This low-flow state does not provide adequate perfusion and is unable to eliminate the occurrence of ischemic damage to vital organs such as the brain during this time. Unlike conventional CPR, ECPR, which provides near normal levels of cerebral and end organ perfusion for days to weeks. Recorded disadvantages of ECPR include significant resource use, patient complications such as infection, thrombosis, bleeding, stroke, and limb ischemia. There is little standardized data to quantify the impact of this intervention. One key determinant of likelihood of survival to ECPR patients is the duration of CPR prior to cannulation. In this meta-analysis, it's hypothesized that the initiation of ECPR for out-of-hospital cardiac arrest patients will result in improved rates of survival to discharge when compared to mechanical CPR with the Lucas device. It is further hypothesized that the intervention of ECPR will result in decreased occurrences of neurological deficits at discharge when compared to continuous and consistent compressions provided by the Lucas device. The purpose of this study is to execute a retrospective meta-analysis producing a thorough review of current literature, evaluating and comparing the efficacy of ECPR and mechanical CPR with the Lucas device for out-of-hospital cardiac arrests. The primary analysis will evaluate these neurological outcomes and survival to discharge for both interventions. The secondary analysis will evaluate the complications of each intervention and short-term and long-term survivability. Inclusion criteria includes individuals that have outside witness cardiac arrest cases that occurred in adult patients only with cardiac etiology. The evaluating population must be below the age of 75, male or female, with no-flow times no more than 2 minutes with early CPR. It also must be documented whether the ECMO placement was completed within 75 minutes of the initial arrest and or the Lucas device was applied after 3 consecutive rounds of conventional CPR. The exclusion criteria included any individuals with severe comorbidities and any individuals who had in-hospital cardiac arrests. They also were excluded for any kind of pre-existing conditions such as irreversible brain damage, terminal malignancy, post-cardiac surgery, any terminal heart failure, severe pulmonary disease, and pregnancy. The Lucas device group included 9 studies, publications ranging from 2006 to 2021, with a total of 5,208 patients. The ECPR group included 10 studies, publications ranging from 2010 to 2020, with 1,221 patients studied. Results for arrest to treatment was recorded. Arrest to CPR time for the Lucas device was roughly 12 minutes, ROSC being achieved in 38% of the patients. Arrest to ECPR time was roughly 55 minutes. To determine significance, the calculated p-value must be below 0.05. When evaluating the positive neurological outcomes for the Lucas device and ECPR, the p-value was insignificant, suggesting that there is no difference in the neurological outcomes between the two groups. Survival to discharge p-value was also deemed insignificant, suggesting that there is no difference between the two groups either. The second part of this meta-analysis sought to assess the short-term and long-term survival categories, along with complications of the Lucas device and ECPR. The p-value for the short-term survival category was less than 0.05, suggesting significant difference between the two groups. ECPR was found to have improved short-term outcomes when compared to patients that were solely treated with the Lucas device. However, when evaluating the long-term survival category, there was no longer a statistical difference between the two groups. Reduced sample sizes were evaluated for complications due to the limited data provided. In the ECPR group, out of 445 patients, 209 incidents of complications were recorded. Some complications included bleeding, leg ischemia, and fasciotomies. In the Lucas device group, out of 2,071 patients, 156 complications were recorded, and those included pneumothorax, vertebral fracture, and cardiac injury, among others. The Lucas and ECPR produced almost equal survival rates in neurological outcomes and out-of-hospital cardiac arrest. This was likely because the survival of ECPR recipients among out-of-hospital cardiac arrest patients were affected by pre-hospitalization factors such as delay before intervention, disruption in CPR, and CPR quality. ECPR is not currently readily available for pre-hospital use, thus making it more difficult to acquire than those in the in-hospital setting due to candidacy status. Studies have shown better outcomes for ECPR in the in-hospital setting when compared to the out-of-hospital setting, mostly due to decreased response time. In Abrams studies, it's a retrospective study done in 5 European centers that demonstrated significantly lower survival with functional recovery using ECPR for out-of-hospital cardiac arrest patients compared to in-hospital cases despite lower burden of comorbidities. This is likely because in-hospital subjects had higher rates of witnessed and shorter low flow times due to initiation of bystander CPR. Out-of-hospital patients are reliant on EMS response time, transportation to ECPR, and cardiac cath lab capable hospitals. Optimizing EMS response time and the time frame between ECPR attempts could potentially improve outcomes for out-of-hospital cardiac arrest cases. The time between cardiac collapse and restoration of circulation is inversely related to the positive clinical outcomes after ECPR. The establishment of pre-hospital ECPR with conventional resuscitation is one approach to shortening this interval and improving outcomes for out-of-hospital cardiac arrest patients. Pre-hospital providers focus on optimizing conventional CPR and advanced life support, achieving recirculation via ECMO, and identifying reversible causes of cardiac arrest. The purpose of this is to minimize the low flow time by delivering ECPR to the patient concurrently with the initial conventional CPR. To further expand, the combination use of the Lucas device may increase the quality of CPR, thus improving the patient's candidacy for ECPR and overall survivability. Limitations of this study include, in general, lack of in-depth information regarding ECPR, where it was performed, how long it took, and standard protocols in the studies. This made it difficult to determine if the differences were attributed to the results or if it was the treatments themselves. In addition, the use of propensity match scores in hindsight would have minimized differences between the two groups and potential confounders that may have influenced the results. Multiple confounding factors and lack of homogeneity among the collected studies made comparisons difficult. In this meta-analysis, the out-of-hospital cardiac arrest patients that received ECPR were seen to have improved short-term and short-term survival. However, in regards to positive neurological outcomes, survival to discharge and long-term survival, there was no significant difference between the two groups. The complications seen in ECPR patients were more prevalent than those obtained in the Lucas device group. Ongoing randomized trials in larger cohorts that actively compare ECPR to Lucas device are needed in order to fully understand the effectiveness of ECPR. And there should be, in general, careful consideration with those results here because there is such differences in the level of studies. Thank you, and are there any questions?